With us Dr. Shikha Bassi, Deputy Director of NEUROOPHTHALMOLOGY Department at Shikha, and she is going to tell us on imaging the optic disc in neuro-ophthalmology. On to you, Doctor.
Dr. Chitra, for giving me this opportunity to talk about imaging the optic disc in neuro-ophthalmology. The aim of imaging is to capture repeatable and reproducible data. Color fundus photograph, fundus autofluorescence imaging using fundus camera have been the time-tested techniques. In the recent past, retinal nerve fiber layer thickness analysis has been captured with good repeatability using these three technologies, that is scanning laser ophthalmoscope, scanning laser polarimetry, and optical coherence tomography. The measurements cannot be used interchangeably within the machines or within the technology. Coming to more recent advances, there has been the addition of enhanced depth imaging OCT, swept source OCT, OCT angiography, and fundus autofluorescence with scanning laser ophthalmoscopy. A new concept has come up where multiple technologies, imaging technologies, have been combined to look at the optic nerve head, looking at its various aspects, and that's called multimodal imaging. In our neuro-ophthalmology clinic, the imaging, optic disc imaging is done using, we have the options of Cirrus by Zeiss, Spectralis by Heidelberg, and we have Atlantis by Topcon. It's a swept source OCT machine. It is a high definition OCT machine, gives a wide field imaging, and the Spectralis, it gives the multimodal imaging option as it has OCT and scanning laser ophthalmoscope both in one machine. We can image the optic disc vasculature with the help of dye, that is fluorescein, and use a mydriatic fundus camera to capture the images, or we can use scanning laser ophthalmoscope or a wide field fundus camera, but a dye is required. Recently, we can do the same using OCT angiography. There's no dye required. Now, of all the techniques that I've enumerated before, the OCT has been very useful in neuro-ophthalmic optic disc imaging. The power of this technology is that it's non-invasive and it's a non-contact technology. It gives beautiful cross-sections of the optic disc. We can look at the structure of the optic nerve head. We can study the PRNFL health. We can look at the ganglion cell health. The high definition OCT, either using EDI or the spectral domain OCT or the swept source OCT machine, these can give us the different segments of the retina, peripapillary retina, the structure, and we can look deep till the lamina fibrosa right underneath the optic disc. Coming to the clinical use of OCT in neuro-ophthalmology, we all know in optic neuritis, in acute phase of multiple sclerosis optic neuritis, there's exoplasmic flow stasis, which causes optic nerve head swelling, becomes evident as thickened peripapillary retinal nerve fiber layer. Over 4 weeks, it becomes thinned out, and this thinning is preferentially involving inferior and superior quadrants in NMO spectrum disorders, whereas in multiple sclerosis, it preferentially involves the temporal and nasal quadrants. But this thickness does not correlate exactly with the visual function of the eye. Whereas the GCC thickness, it correlates better with the visual dysfunction in terms of acuity and fields, but it takes around 2 weeks for it to become evident. Severe thinning is seen in NMO spectrum disorder disease. Can peripapillary retinal nerve fiber layer analysis be used to diagnose tumors like pituitary adenoma? This is the RNFL thickness of the patient with pituitary adenoma. We can see on the right side, the RNFL is normal. On the left side, that is left eye, there are some changes. Thinning is appearing on the left eye. Look at the visual field, it's giving much more information than the OCT. Whereas in the ganglion cell health gives more information than the RNFL. We can see here a hemianopia on perimetry can present as hemimacular atrophy on the GCC thickness map. and it may occur even earlier than the automated perimetry. For sure, it occurs before the RNFL thinning. OCT can also be used to monitor papilledema. This is the RNFL thickness pre and post treatment. But a word of caution, you also have to look at the ganglion cell thickness, because if both are reducing, that means your treatment is not working. Ganglion cell health has to be normal if the RNFL thickness is decreasing. Another place where OCT is very useful is differentiating between optic neuritis and subtle maculopathies like Azure and HCQ toxicity. We have Dr. Bassi with us, so let's look at some of the congenital optic disc anomalies and their OCT characteristics, which have been studied, defined, and have been used as a diagnostic adjunct. This is the OCT image of the optic disc pit, and it's showing, it's a high definition wide field image. It shows the pit and it's showing the static changes at the macula, but there's no SRF. This is a case of optic disc coloboma where the pit was also simultaneously present, and we could capture it with the OCT technology. Here we can see it on the image, fundus image also. What is this? This is not the optic disc. This is choroidal. This is a section through the choroidal coloboma. Let's take it up through the disc, and we see a large excavation here. Why I call it large? Let's look at a normal OCT image. And in comparison, the upper image is showing there's a deep excavation, which is not glaucoma, feels is normal. So this is an aborted disc coloboma. It's a patient with morning glory syndrome. This disc, the OCT features of this disc, the neurosensory detachment can be picked up on OCT. There is a periphery hyperreflective ovoid mask-like lesion, which has been picked up on OCT. This is the neuroglial tissue on the surface. In hypoplastic disc, there's severe RNFL thinning associated with decreased disc area. Coming to the OCT in optic disc drusen's and pseudopapilledema, this is my publication in 2014, where we described the presence of a hyperreflective echo in the subretinal space in patients with pseudopapilledema.
1 minute remaining, ma'am.
Sure, thanks. So this is the difference between true papilledema and pseudopapilledema. There is a hyperreflective area in true papilledema, whereas there is a hyperreflective echo in pseudopapilledema. But with the emergence of better high definition imaging technology in OCT, the drusen has been defined as a hyporeflective area with hyperreflective pronated margins. A consortium was formed to study it. It's given a protocol. It requires STOCT, 97 sections, and presence of autofluorescence to confirm presence or absence of optic nerve head drusen. The forms, which I have repeatedly mentioned in my previous slides, is actually herniating optic nerve fibers. The latest in the imaging in optic nerve head drusen is this paper, where multimodal imaging using the OCT and scanning laser ophthalmoscope using simultaneously 3 wavelengths of light, that is red, infrared, green, and blue, have been used to study the OCT characteristics of optic nerve head drusen. This is my last slide. OCT angiography can be used to study ischemic optic neuropathy, study in detail the optic disc vasculature, the blood supply to it, but its use is limited because it cannot be used in swollen discs. Thank you.
Thanks a lot, Dr. Shikha. That was again another wonderful talk. I think we should sit and hear it all over again. Can there be a selective GCC loss and or RNFL loss, one or the other not happening?
Yeah, it all depends on the timing. As I said before, that you can have, it takes around 4 weeks for RNFL loss to appear, and it takes 2 for RNFL loss to appear. In ischemic optic neuropathies, the GCC loss is very immediate. It occurs very fast. RNFL, if it is anterior ischemic optic neuropathy, you will obviously have the RNFL thickening also. But the thinning part of RNFL, that takes time. So when we are talking about changes in RNFL and GCC, it is the thinning which has any implication, and it occurs sooner in patients. It's more evident in GCC than in RNFL. I've already shown
Yes.
my patient with pituitary adenoma,
Yes,
where the
yes.
GCC was affected and RNFL was normal.
Yes, yes. Murli, you have anything to ask before we go on to our
Yeah, the appearance of optic disc drusen, Shikha. I mean, does it depend on the stage of the drusen? Like only after calcium deposition, the hypo dense
Yeah.
with hyper dense crenated margins come on. Is that true? I mean, the stage of the optic disc drusen will determine the appearance on OCT. Is that true?
Yeah, that's what Murli, the consortium has defined the optic disc drusen as a hyporeflective echo surrounded by a hyperreflective crenated margin. That is the description of a calcified drusen. What happens in certain cases of pseudopapuloedema, especially in children, the drusen is not calcified. And in those cases, what we see is forms. These are, you don't really capture these drusens. What you see is these herniated axons. So we are not able to pick up drusens in all pseudopapuloedema.